Hello, in this video, I will be talking about the ways in which being premenopausal affects recommendations for endocrine therapy or hormonal therapy. Before I go on, I'd love to invite you to subscribe to our channel. We're always putting out new content, and you can suggest a video below in the comments if there's something you would love to see. I'd also love to invite you to go to Yerbba.com to get your personalized report. So endocrine therapy or hormonal therapy and premenopausal status. Let me just back up a little bit and explain how we define premenopausal status. Somebody is considered premenopausal if their ovaries are making estrogen, even if they're not having periods. So for example, I'm going to use an extreme. You could be pregnant and not having periods. You're not postmenopausal, you're premenopausal. You might be on birth control pills and you don't have periods regularly, or you might have polycystic ovary disease or any one of a number of conditions that stops you from menstruating, yet your ovaries are still working. Ovaries make estrogen, progesterone, testosterone, and a whole host of other hormones. In somebody with breast cancer, and if the breast cancer is hormone receptor positive, and you may want to check out our video about hormone receptors, endocrine therapy is different if your ovaries are still making estrogen and all those other things than if they're not. Perimenopausal is a separate case, but in general, people who are perimenopausal, who develop breast cancer, are considered premenopausal until they're no longer premenopausal. When we're sure that they have completed the menopausal transition, they're considered premenopausal. Ovaries are still making some degree of hormones. In people who are premenopausal, the most common endocrine therapy that is offered is Tamoxifen. The aromatase inhibitors on their own do not work in people whose ovaries are still making estrogen. The ovarian estrogen actually increases in people on an aromatase inhibitor if the ovaries are still functioning. So for ductal carcinoma in situ, very low-risk breast cancer, Tamoxifen is the endocrine therapy that is recommended. In people who have high enough breast cancer risk that chemotherapy would be recommended or offered, even in the person who doesn't want to get chemotherapy or decides not to, suppressing the ovaries with an injection, I'll tell you more about in a moment, along with Tamoxifen or an aromatase inhibitor, gives additional benefit. So let's say somebody, I'll give you two cases. Somebody who's been through chemotherapy, they had high enough risk disease that chemotherapy was offered and accepted, and that patient still has ovarian function after chemotherapy, as many people do. We recommend, in many cases, putting the patient on an injection of an LHRH analog. We have a whole video about LHRH analogs, but in brief, these medications induce a medical menopause. So they tell your body and your ovaries to stop making estrogen. In the vast majority of times, it's reversible, and it's a way to suppress the ovaries without removing them. So you still have your ovaries in your body. Once the injections stop, your ovaries wake up again. Some people who are close to going through menopause may have the suppression of their ovaries with the injections and then proceed to having the ovaries removed surgically for one of many reasons. Or somebody who has an inherited susceptibility to ovarian cancer might choose to have their ovaries out as well. So there are lots of reasons why people might have their ovaries out, or the injections aren't available in their country, or it's too far for them to travel. If you live 6 hours away from your healthcare provider, you don't really want to do that once a month. So ovaries can also be removed. Then that person can be on an aromatase inhibitor. Again, you can't have any ovarian function and benefit from aromatase inhibitors in terms of reducing your risk of breast cancer recurrence. So I'm going to summarize what I've said, and then I'm going to go into another case. So aromatase inhibitors, not used in people with functioning ovaries. Tamoxifen is the endocrine therapy of choice. The exception is in people who still menstruate after chemotherapy and had high enough risk. They will be offered an LHRH analog or removal of the ovaries. Your situation is unique, so I can't tell you exactly what to do in your situation. But if you're interested in learning more, going to Yerbba.com and getting your personalized report might be helpful. Your Yerbba report takes all your medical records after you give Yerbba permission and creates a report of all the things we know about the tumor, all the things we have yet to learn, and then all your treatment options. And it does that by looking at the most up-to-date medical evidence, and then creates a report that tells you all your options, the pros and cons of each, why that option might be recommended for you, and it does it all in easy to understand language. So if this video has confused you, consider going to Yerbba.com to get your personalized report. Drop a comment or question below. We get back to you within 1 to 2 weeks. Thank you so much for watching, and we'll see you next time.